lower back, or lumbar spine, is a complicated structure which bears a lot of weight while allowing movement of the back. There are usually 5 bones, or vertebrae, that stack up to make the lumbar spine. The vertebrae are separated by joints known as discs. Together, the vertebrae and discs make up the spinal column, which supports most of the upper body's weight. The vertebrae are numbered from top to bottom as L1, L2, L3, L4, and L5. It may help to think of this portion of the spine as a stack of coffee cans separated by jelly donuts. The jelly donuts, or discs, have a thickened jelly-like material in the center called the nucleus pulposus, surrounded by a gasket called the annulus, which contains the jelly. Adding weight to the spine raises the pressure in the center of the disc while allowing the adjacent coffee cans, or vertebral bodies, to move, rotate, and bend while resting on this soft cushion. The spinal column is supported by another row of joints called facets, which are located in the back of the spine. These joints mostly provide stability with bending motions. The spinal canal is located behind the stack of vertebral bones and discs. The spinal cord ends at the top of the lumbar spine, but sends nerves downward through the spinal canal to supply movement, sensation, and reflexes to the legs. Lumbar disc herniations occur when the gasket surrounding the soft, jelly-like center of the disc develops a crack. The semi-solid contents of the disc space are usually under pressure, which increases substantially with lifting, and the jelly-like material may be forced through the crack in the gasket to end up within the spinal canal. This is more likely when the low back is bent forward because the disc is wedged toward the back of the body, directing the disc jelly back toward the part of the gasket next to the canal. Twisting while lifting worsens the situation by relaxing alternate portions of the disc gasket and weakening the band meant to contain the disc jelly within. As cracks in the disc gasket develop over time, people begin to experience back pain. If the disc jelly ruptures through the gasket, back pain may initially improve, but be immediately replaced by pain or numbness down into the buttock and leg as a nerve within the spinal canal is compressed or pinched. The disc jelly substance is chemically irritating to the nerve as well, and the nerve becomes inflamed and swollen as a result of the irritation and compression. The nerves passing through the spinal canal in the lower back contain a mixture of fibers which provides sensation, movement, and pain sensation in a very precise, predetermined portion of the leg. Irritation of a lumbar nerve usually causes a mixture of pain, numbness, tingling, and weakness, which begins in the low back, passes through the buttock, and then into the specific part of the leg that the nerve supplies. Initial treatment of this pain down the leg, or sciatica, is directed at reducing the inflammation of the nerve in response to the disc herniation. This can be accomplished by reducing activity, avoiding activities or positions which pinch the nerve, taking over-the-counter anti-inflammatory medications such as Motrin, ibuprofen, or naproxen, or oral steroids, or injecting a steroid medication into the spinal canal close to the inflamed nerve. That's called an epidural steroid injection. Other measures such as massage, the use of hot or cold packs, ultrasound, narcotic medications, or a TENS unit may help reduce the perception of pain and make the situation more bearable. Over time, the inflammation surrounding the nerve root improves, and the pain and other symptoms usually diminish or disappear in about 2/3 of the patients who initially experience sciatica. That's why the initial treatment for this problem emphasizes reducing inflammation, avoiding re-injury of the nerve, and waiting for nature to reduce the symptoms. Active exercise and physical therapy is usually not a very good idea during this inflammatory phase. A very good response to oral or injected steroids may also indicate the proportion of the problem which is related to nerve inflammation rather than physical compression of the nerve, providing hope that with time, patience, and persistence, that the problem will resolve on its own. If the symptoms have not resolved in 4 to 6 weeks after onset, then it's likely that physical compression, not inflammation, plays the major role in keeping the nerve unhappy. In this circumstance, or if substantial leg numbness or major leg weakness is present at any time, then removal of the material compressing the nerve with surgery is usually the best treatment option to resolve the symptoms or restore sensation and strength to the leg. There are different surgical techniques for removing a herniated disc, but I'm going to talk about a minimally invasive surgical method to relieve the pressure on the nerve root. With this type of surgery, a small incision is made in the back, under 3/4 inch long. A thin wire is passed through the incision and the muscle underneath to arrive at the bone covering the spinal canal, also called the lamina. This wire is directed during surgery using X-ray guidance, with the patient asleep under general anesthesia, lying face down. A small tube is then passed over the wire down to the lamina, pushing the muscle fibers slightly apart. 2 or 3 more tubes are then passed, one after another, like a set of Russian dolls, to continue to separate the muscle fibers until a final tube about 1/2 inch in diameter is in place. The surgery is performed through this final tube using an operating microscope which provides magnification and a bright light to make microsurgery possible. This type of technique is called a microdiscectomy. A small, high-speed burr is used to make a minimal opening in a portion of the bony lamina covering the spinal canal, a step referred to as a hemilaminectomy. The bone removed to make this opening does not grow back, but is not structurally important, so the spine is not significantly weakened as a result of the operation. An opening is then made through a thin ligament within the canal, which allows the surgeon to see the affected nerve and the disc material that's compressing it. The nerve is protected as the disc herniation is removed. Disc material looks and feels like crab meat. With the removal of the disc herniation, the nerve is free to return to its normal position. The hole in the disc gasket from which the disc herniation emerged is usually visible, and any loose disc material within the disc space close to this opening is also removed to decrease the chance that another disc herniation may occur later in the same location. The tube is then removed, the muscles next to the spine resume their normal position, and a few stitches are placed just under the skin surface to close the incision. For most individuals, this surgery lasts about 45 minutes to an hour, involves about a tablespoon of blood loss, and is almost always done as an outpatient surgery. Most minimally invasive surgical patients are comfortable and walking within several hours of the surgery with very little incisional pain. Most also experience resolution of their sciatic pain upon awakening from anesthesia. Patients are usually able to return to most of their activities within about 2 weeks, although certain precautions, such as reduced sitting, bending, and lifting, are recommended for at least 4 to 6 weeks after surgery. Physical therapy is not usually necessary unless there is significant leg weakness present before surgery, or an individual must return to a physically demanding job. As with any medical procedure, there are risks with minimally invasive lumbar disc surgery. The most likely risk to occur is failure to satisfactorily reduce the symptoms or problems arising from the disc herniation. The chance of surgical failure, having a patient return 6 weeks after surgery and report that the surgery was not helpful or not helpful enough to justify the discomfort and expense is between 5 to 8%, about a 1 in 10 chance of failure. If you are an optimist, the chances of success with surgery are between 92 and 95%. When surgery fails, the most common reason is that the disc herniation which was removed was not the cause or the only cause of the leg and buttock symptoms. This is the reason that careful and complete evaluation is necessary before surgery to exclude other causes of buttock and leg pain. Blind reliance on lumbar MRI reports or findings without taking care to ensure that the symptoms and neurological findings match those expected from a disc herniation's location increase the chances of surgical failure. Other problems are also possible after surgery. The worst outcome from surgery would be to cut or irreparably damage a nerve in the process of removing the bone covering it or the disc material compressing it. I performed this type of minimally invasive spinal surgery in the lumbar spine between 200 and 300 times a year. I haven't cut a nerve in 25 years of practice, so the chance of this occurring is not zero, but it's pretty small. Wound infection, bleeding in the spinal canal requiring reoperation, or spinal fluid leakage through the incision are all possibilities after spinal surgery. In people who have a good result with surgery, there is still concern that a new disc herniation at the site may again cause symptoms. In fact, even people who don't have surgery remain at risk for pushing more disc through the opening in the disc gasket and reigniting the symptoms of leg pain. For every 7 patients who undergo surgical removal of a disc herniation, 1 will return within the next 5 years with a recurrent disc herniation at the same level. Some recurrent disc herniations require reoperation, usually through the same incision and usually with the same good symptom relief after reoperation. The risk is higher in people who are overweight or have jobs or recreational activities which require heavy lifting, repetitive bending, or prolonged sitting. This is the reason for the activity restrictions recommended immediately after surgery and for recommended lifestyle changes once a person has suffered a disc herniation. What is the bottom line regarding lumbar microdiscectomy surgery? If the symptoms from the disc herniation can be accurately described as occasional, minor, trivial, a nuisance, minimal, or manageable, there is no compelling reason to consider surgery. If, on the other hand, the symptoms continue at an unacceptable level despite an appropriate, reasonable course of focused non-surgical management, if these symptoms keep a person from doing things that they have to do, like working, or things that make life enjoyable, then surgery is a better alternative than living with the pain and limitations of a disc herniation. As this video continues, our experienced nursing team will cover some important points that you should know as you prepare for surgery.
You will need a preoperative physical exam within 30 days of your scheduled surgery date to ensure you are healthy enough to tolerate anesthesia and your surgical procedure. This can be with your primary care physician or any other primary care provider. Our surgery scheduler will assist you in setting up this appointment. We ask that you stop taking aspirin, ibuprofen, Aleve, and all other NSAIDs or non-steroidal anti-inflammatories 1 week before surgery. You may continue taking Tylenol if needed. If you are on any anticoagulants or antiplatelets, such as warfarin or Plavix, you will receive special instructions from your doctor regarding stopping and restarting these medications. If you are taking medication for diabetes, your doctor may recommend adjusting your dosages. Your primary care provider will provide you with instructions about any other medications or supplements that you take at your pre-op visit.
If you are currently smoking, we will ask that you quit now. Nicotine decreases the ability of blood vessels to carry oxygen and nutrients to your spine. It has been shown to cause delayed healing and poor surgical outcomes. For help quitting smoking, please talk with your doctor. Do not eat anything after midnight the night before your surgery. You may drink water, Gatorade, tea, and coffee without cream up to 4 hours before your surgery. You may take medications that your doctor has okayed with a small sip of water. Do not drink alcohol for 24 hours prior to surgery.
Most lumbar spine surgeries involve an observation stay in the hospital, and most patients go home the same day as surgery. You should expect to get out of bed with assistance when you get to the observation unit. Before going home, your nurse will make sure that you are able to walk and go to the bathroom, that your pain is under control, and that you are able to tolerate oral intake of medication and food. Everybody's surgical experience is different, and everyone has a different perception of pain. You may feel resolution of your pre-surgical pain, but you may still experience some of that pain as you heal. It is normal to have some pain at your incision site and to have muscle spasms or tightness. Some of your pain may also come from irritation or swelling around the nerve, and this can take some time to resolve. Numbness and tingling usually takes a longer time to subside and may continue improving for up to 1 year after surgery. You will most likely receive a prescription for a narcotic pain medication and muscle relaxant prior to discharge. Under most circumstances, you will be weaned off these medications within 4 to 6 weeks after surgery. Though you may need to take these medications more frequently in the first few days after surgery, they should be taken only as needed. You should begin taking less of the pain medication as your pain improves. If you have long-term pain management needs, you will need to discuss this further with your primary care provider.
We will ask you to hold any aspirin or NSAIDs such as ibuprofen, Aleve, and Celebrex for 2 weeks after surgery due to these medications increasing your risk for bleeding. Acetaminophen or Tylenol is okay to use for mild pain. However, please note that there is acetaminophen in Percocet and Vicodin. When you get home, walking is the best exercise. You should take short, frequent walks and change positions for your comfort. Try to avoid sitting for longer than about 30 minutes at one time. You will need to avoid repetitive bending or twisting at the waist, and your lifting will be restricted to 10 pounds for 6 weeks. Stairs are okay in moderation. Avoid strenuous housework or yard work until your first follow-up appointment. Physical therapy is not typically required after surgery. However, your surgeon will evaluate your specific situation to determine if it would be beneficial.
Your incision will most likely be covered by a bandage when you leave the hospital. You will keep this bandage on your incision for about 48 hours after surgery. After 48 hours, you will remove the bandage and keep your incision clean, dry, and open to air. You may also shower at this time. It is okay to get soap and water on your incision. You will need to avoid soaking your incision, such as in a bath, hot tub, or swimming pool, until it is completely healed. Do not apply any creams, lotions, or hydrogen peroxide to your incision. Most incisions will be closed with an internal, dissolvable suture that does not need to be removed. Please call our clinic if you notice any increased redness, swelling, or drainage from your incision. Anesthesia, narcotic pain medication, and immobility can all lead to constipation. It is much easier to prevent constipation than to treat it. Drink plenty of water, increase fiber in your diet, and make sure you are getting up to walk. We recommend taking an over-the-counter stool softener such as Colace or Senna while you are taking narcotic pain medication.
Returning to work will largely depend on the type of work that you do, as well as your specific procedure. You can expect to be off work completely for at least 1 to 2 weeks after surgery. You and your surgeon will work together to come up with a plan for your individual needs. Your first scheduled follow-up appointment will be with a nurse from our care team about 10 to 14 days after surgery. Your second follow-up appointment will be about 6 weeks after surgery. At this visit, you will see one of the physician assistants or nurse practitioners. You should call the clinic if you notice any signs or symptoms of an infection, such as fever or increased redness, swelling, or drainage from your incision. Please report any calf pain or tenderness, chest pain, or shortness of breath immediately, as these may indicate the presence of a blood clot. Let's take a moment to look back and review some of the key points from this video. First, remember to schedule a preoperative physical exam with a primary care provider within 30 days of your surgery. Stop taking aspirin, ibuprofen, Aleve, and all other anti-inflammatory medications 1 week before surgery. Also, we will ask you to hold these medications for 2 weeks after surgery. If you are smoking, please seek help to quit as soon as possible. The night before surgery, do not eat anything after midnight. You may drink water, Gatorade, tea, and coffee without cream up to 4 hours before surgery. Do not drink any alcohol within 24 hours of surgery. When you get home, you should take short, frequent walks. Avoid bending and twisting at the waist, and limit your upright sitting to about 30 minutes at one time. Do not lift more than 10 pounds for 6 weeks, and avoid strenuous house and yard work. 48 hours after surgery, remove your bandage and leave your incision open to air. You may shower after you remove this bandage. Do not soak your incision or apply any creams or lotions. Your follow-up appointments will be scheduled for about 2 weeks and 6 weeks after surgery. Remember to call the clinic if you notice any signs of infection, which include fever and increased redness, swelling, or drainage from your incision.
Please reference the day of surgery video for more information about what to expect when you arrive at Methodist Hospital for your surgery. As always, we are happy to discuss any questions you may have at your clinic visit or by telephone. We want to ensure that you have the best experience possible and receive the very best care. Thank you for your time.